Okay, hello everyone. This is another topic under the clinical psychology. So here we'll be looking at anxiety and fear related disorders. Okay, yeah, overview of anxiety and fear related disorder. Do not forget we're going to be looking at the diagnostic criteria. All right, and then the second part we'll be looking at the explanation, which is the same thing as the causes. And then the last one, we'll be looking at the treatment. Those are the major things we're going to be looking at. All right, now talking about the definition and core features. It's characterized by excessive fear and anxiety that lead to significant distress. Okay, now one thing about the anxiety issue or disorder is that it must lead to a distress or impairment in important areas. All right, if it doesn't really affect the person as such, okay, I think to some extent a lot of people fear certain things, right? But it doesn't actually impair their daily functioning. They're still able to cope with majority of the things in the society, then that is fine. Okay, if you have fear for snake, for example, and you don't have snake around the environment, so you don't, it doesn't really affect you as such. But if you have fear for things that really affect you, that stops you from doing certain things, okay, you're unable to do other things in the society, then it can be a serious situation, right? Now, key distinction: fear is a response to a perceived imminent threat in present. Anxiety, on the other hand, is linked to anticipated or future threat. Okay, so fear actually is logical because you can see something right in your presence, okay, or let me see something dangerous around your vicinity. So if you're scared of that, if you express fear, that is understandable. If you see a gun, you're scared, yeah, that is fine, right? But anxiety can be something like, okay, you just anticipate the threat, or maybe something you see is so small that the thing cannot instill a particular damage, or let me say it can cause you harm, but then you fear it as though the thing is very dangerous, then that can be anxiety, right? Now, differentiation: disorder are differentiated by the specific stimuli that trigger their fear or anxiety. Now, moving forward, we have generalized anxiety disorder, which is known as the GAD. Okay, now symptoms: it's marked anxiety and worry most days, okay, for several months. You express anxiety and worry, okay, for majority of the days, and then it lasts for several months. Now, worry can be general or focus on everyday issue. For example, health, family, finance, work. Now, this is the kind of worry that is being exhibited in the GAD. You just worried about, okay, for example, how do I cope with my work? It becomes so burdensome for you that you're thinking a lot about it, then that is anxiety. Or you're thinking, okay, how do I become a good husband? All right, how do I become a good wife? Okay, how do I train my children very well? And that affects you so much. All right, then that is anxiety. Okay, physical symptoms accompanied by muscular tension, all right, sleep disturbances, okay, concentration difficulties, irritability, and many others. Now, how does that affect? It causes significant distress or impairment in functioning. All right, now, exclusion criteria: what are the factors that will not make it, or let me say symptoms to be categorized as anxiety? Must not be attributed to another medical condition or substance or medication. So if you're showing anxiety due to response to a particular to any of this, then it is not general anxiety disorder. All right. Okay. Now moving to phobia. We have okay. What is phobia? Phobia actually is an excessive fear or anxiety towards a particular stimuli or stimulus, rather. Okay. Now, in this situation, we are referring to a particular thing, as compared to GAD, where the anxiety is just you're just worried about being something. There is no object involved. Okay, so it can be general towards everything. It's an approach now. All right, this on the other hand is rather a fear exhibited over a particular object, which is the stimulus. All right, now Looking at agoraphobia as an example, excessive fear or anxiety about situation where escape might be difficult or help unavailable. Right? For example, okay, public transport, crowded places, being alone outside. Okay, if you feel right, you just perceive that escape might be somehow difficult around the environment, then that is an example of agoraphobia. All right, specific fear of experiencing panic attack or embarrassing symptoms in public. Okay, these are the kind of fear the person exhibits. Now, behavior, avoidance of this situation or enduring them with extreme distress. So it's either two ways: is that the person avoid or endure such behavior with extreme distress. Okay. Now, duration and impact. Symptom persist for several months and significantly impair daily functioning. Right? It affects the daily behavior. Now, specific phobia. In this study, we'll be looking at the BII, which is the blood injection injury. Okay. BII, blood injection injury. All right. Now, symptoms: excessive fear or anxiety specifically related to the site of blood. That is the BII. Okay. It's related to the site of blood. So it's for a particular stimulus. Okay. Now, site of blood, injection or injury. Okay, so it's related to all of this. Now, the fear is disproportionate to the actual danger. Can you see? It's not in relation to the actual danger. I mean, blood or injection or injury does not pose that type of danger as compared to the way the people show excessive fear for it. Now, what is the behavior? The individual either avoids the phobic stimulus or endures it with intense distress. Okay, now duration and impact. Symptoms must persist for several months and lead to significant impairment. Can you see? So, all right, duration for this, it must be something that has been happening for a period of time. So before it can be categorized, as BII. Now, key point: diagnosis require that the fear is not better explained by another disorder or substance use or intellectual impairment. Now, moving on, what are the key terms? You have the psychiatrist, a medical doctor specializing in diagnosis and treating mental disorder. All right. So, psychiatrist is a field related to the medical field, right? Okay. So it's related to the medical field, but they are specialized in treating mental disorder. All right. Psychologists also, they are specialized in treating, for example, mental disorder as well, clinical psychologists. However, it is mostly through CBT, cognitive behavior therapy, all right, through therapies. All right. Medical psychiatrists, on the other hand, they are licensed to go beyond just talking. I mean, they're not specialized in talking, but rather they can go ahead and check the dopamine level, check the neurotransmitters, the brain structures, and other things to see what is wrong with the person. Now, what about BII? Is BIPI. This is a self-report measure used to assess the severity of BII phobia. Okay, to know the severity of someone's blood injection and injury phobia, right? Now, moving forward, we have the GAD-7 tool, which is a questionnaire, a form of measurement. It's a screening tool, all right? Not the exact diagnostic criteria, or let me say the diagnostic tool. Okay, it's just a screening tool that can be used to measure the severity of anxiety. All right, assessment items assess feelings such as nervousness, restlessness, and fear that something awful might happen. Okay, scoring, it has a score of 0 to 3 scale. Okay, 0, which means not at all, and 3, nearly every day. Okay, to show how much you experience that feeling or thought. Now, usage primarily used in primary care setting to determine whether further referral is needed. So it's a screening tool, like we said earlier, to refer someone for further checkup if needed. Okay, now the BIPI rather, okay, it's a structure self-report which measures 18 different scenarios involving blood and injection. Okay, now respondents rate their cognitive, which is their thought process, their physiological, which is the movement in the part of their body, talking about their arousal level, and then their behavior response on a scale of 0 to 3. Okay, now example, it contains 18 different scenarios. This is an example of one of the scenarios, right? When seeing blood, a person might rate, okay, cognitive response. I think I am going to faint on a scale of 0 to 3, either never or always. Okay, when seeing blood, this is the scenario setting. Cognitive response, this is this. So you're going to rate. Okay, the purpose used to determine the severity of the BII phobia and track change following therapy. Right now, example study, we have a study by Mars et al. In 2010. What is the objective? To evaluate whether the BIPI can effectively discriminate between individuals with and without BIPI. That is well understandable, right? To see if it can be used to measure, to assess if someone with blood phobia, the BII phobia, and then the other person without it. Okay, methodology. 39 participants diagnosed with BII phobia compared with an age and gender match control group, right? So you try to match this participant in terms of age and the gender to form the control group. Now, participant completed the BIPI and the fear questionnaire FQ to measure related anxieties. Now, what did the findings show? The BIPI demonstrated excellent reliability and internal consistency. Okay, so it is effective. Showed strong concurrent validity with the blood phobia subscale of the FQ, which is the fear questionnaire. So fear questionnaire also has the blood phobia category under it. So the BIPI and that category shows concurrent validity. So those that rated high here also rated high there, effectively discriminating between those with and without BII phobia. Now, sensitive to detecting reduction in phobia severity post-treatment. So it's also good for that. If someone has been taken through treatment and you want to check if there is an improvement or not, you can use the BIPI as well, right? Okay. So evaluation of the research method used. Strength we use is a quantitative data, right? Which measures it provides objective data that can be compared across studies, right? So objective data means there is no bias, free from bias. Also, concurrent validity with the subscale of FQ questionnaire shows its credibility, right? What is the limitation, however? Is dependence on self-report, so there can be what? Social desirability, all right? And on usually stressful day might skew results. So there are other factors that could affect the person's mood to respond and certain things, right? Now, this tool assess a single dimension and may not capture the full nuanced experience of an individual's anxiety or phobia. Okay, so it assess a particular category talking about the 18 different scenarios. You might not be able to fully assess the environmental factors the person or the people find themselves, you see. So those are the challenges. All right, now issues and debate, psychometric limitation. So the BIPI is a psychometric test. All right, now quantitative assessment may not fully capture the complexity and lived experience of anxiety disorder. Right, critics argue that relying solely on numerical score can overlook individual variation in symptom presentation. All right, so you might not be able to provide the in-depth analysis, all right, the exact reality each individual might be experiencing. Okay, what about cultural consideration, diagnostic criteria, and assessment to develop in Western culture may not fully apply to non-Western population, you see. All right. For instance, BII phobia might be less relevant in culture where medical procedures are infrequent. Okay. Similarly, experiences of GAD and agoraphobia might differ based on cultural context, e.g., reliance on public transport, typical social environment. Okay. So there could be cultural differences. Talking about how the BIPI was created to analyze and measure the agoraphobia. Okay, in another culture, it might not capture the behavior they exhibit. Okay, it might not really mean exact same level of avoidance, or maybe they might have, but the way they show their phobia now, the way they react to their phobia might be different, right? So, moving forward to the explanation now, what is the cause of anxiety? Okay, we have the genetic basis, that is the genetic predisposition. The genetic explanation suggests that humans are born with a predisposition to fear specific object or situation. Is that true? Well, that is according to genetics, that there are certain things that humans fear, and we fear those things in order to be able to survive. Okay, there are certain things that are dangerous, that are harmful. So humans over time are beginning to have genes that helps us um, fear those objects, those things. All right. So evolutionary advan- evolutionary advantage. Certain stimuli in the environment may pose threat to survival, right? And we are genetically programmed to avoid them. Okay, generational transmission. This fear response is transmitted through DNA across generations to enhance survival, right? So that's according to genetic explanation. You can keep that in mind. Very important. Yeah, moving forward, example study by Ost 1992. Now, he used 81 participants with blood phobia and 59 with injection phobia, compared with individuals diagnosed with other specific phobia. All right. So, but 81 blood phobia, 59 injection phobia. All right. And he compared them with others with other specific phobia. Method: screening interview, self report questionnaire, behavioral testing, which, because they were asked to watch a surgery video, they were also observing their behavior. Fingertip, uh, fingertip prick process. Okay. Now, measures. They had a performance score, experimental rating of fainting behavior. Okay. And then there was a self report through the interview. Okay. On the anxiety level, heart rate, and blood pressure monitoring. So, those were the measures used by OST. Now, findings: 50% of blood phobia sufferers had at least one parent with the same phobia. Can you see that? So 50% of them, they have at least one parent with the same phobia. So which shows the possibility of a genetic transmission. Now, 27% of injection phobia sufferers had a parent with the same condition. Can you see? 27 same, 50 same. All right. High incidence of fainting among blood and injection phobia participant. All right. So they also discovered that there is a high level of fainting when it comes to the blood and injection phobia participant. So actually, the reaction to other kind of phobia um, might be just avoidance, but when it comes to blood, people tend to faint a lot when they see blood. Okay, when they see blood or things relating to blood, they just faint. Okay, so it's common with that particular phobia. All right, so 50 here with the same phobia, so 27 here with the same condition. All right, so however, this doesn't necessarily show the causal effect, but there is a tendency, only showing the possibility. All right, that there could be genetical explanation. Now, moving to the psychological explanation, we have classical conditioning, looking at the behavioral approach, right? Now, phobias may develop when a neutral stimulus, that is NS, is compared with a frightened experience, which is unconditioned stimulus, creating a learned fear response. What do we mean by that? Neutral stimulus, which is something you do not have any fear for, right? You do not have any phobia, any issue with something. Okay? Now, when it's being paired with a frightening experience, something you do not like, which is the unconditioned stimulus now, it creates what is known as conditioned stimulus. Neutral stimulus plus unconditioned stimulus create conditioned stimulus. When you check your course books, you will see the situation of the little Albert experiment. Okay, now in the little Albert experiment is an experiment showing a baby who does not fear white rat. Okay, rat generally. So the baby, which is Albert, he was playing with the rat. He had no issue with the rat. So that is the neutral stimulus. It doesn't have any effect on the baby. Now, there is something that has effect on the baby, and that is a loud noise. A loud noise actually makes the baby scared. All right? So now, a loud noise now is unconditioned stimulus, which actually make the baby scared. So that thing has an effect. But rat, on the other hand, doesn't have an effect. Now, what they did in the experiment is to pair each time the baby see the rat, they make the loud noise. So there is a connection, there's an association between the stimulus that has effect and the stimulus that does not have effect. All right. So now when they combine this together, obviously it will get to a point that when the baby see the rat now, even without the loud noise, the baby became scared of the rat. All right. So now the rat now has become a conditioned stimulus. All right, which is producing a conditioned response. Okay, now example: a person mugged in a public place may develop agoraphobia. All right, so there is this bad experience. Now, if he attaches this experience with the public space, now agoraphobia, he won't want to go to that public space anymore. All right, so that is the classical conditioning. Operant conditioning, on the other hand, is negative reinforcement. Okay, looking at negative reinforcement in this situation, we also have positive though, which plays a key role in phobia maintenance. All right, avoidance of the phobic stimulus reduces fear, right? There are some stimulus that actually they're fearful. So now when you avoid them, it reduces your fear, right? So it is a way of a negative reinforcement. You're trying to be happy, so you try to stay away from something that brings the fear to you, reinforcing avoidance behavior. Okay, example: someone with a duck phobia, duck, right? Phobia for it, avoid parks because they can easily be found there. Okay, which removes fear and reinforces avoidance behavior. So it takes away the fears, and then on the other hand, the behavior is being exhibited over and over again. Okay, example study done by Watson. Oh, yeah, I just explained this already. Watson and Rayner, all right, the little Albert experiment. A healthy 9-month old boy, just 9 months, not even up to a year, all right, precondition exposed to various stimuli, wild rat, rabbit, dog, monkey, mask, etc. Showed no fear. He's not scared, right? Babies are naturally playful with animals, right? Now, loud noise is the issue. If he hears a loud noise, it elicits fear from the baby. All right. Now, when they paired white rat with loud noise now, over multiple times, over and over again, it results to what? Seeing the rat alone now, the baby became scared. Can you see? So Albert's fear extends to other fury animal, any other animal that has um, the this the f- the hair around the body. Yeah, any other animal that has that. Okay, so for example, rabbit and similar animals. So that is it. So this study showed that okay, people can have phobia due to such connection, right? Now, what about the psychodynamic explanation? which is according to Freud's theory. Now, there is an unconscious conflict. There is a fight between two things. We're going to talk about that. Now, it said anxiety and fear stem from unconscious conflict, often due to repressed impulse from the ID. Okay? When you suppress the impulse of the ID, it creates a conflict, according to Freud. Now, what is ID? ID is more like let me put it this way, just your adventurous mind. Okay, a part of you that wants to try different things, that wants to go against the norm, that want to, that want to do just like a subconscious thought. You want to do this, you want to do that. Maybe, for example, you're trying to cross a bridge and then the thought just came to you, jump. All right, or maybe you're just trying to um, you're just trying to do something in the kitchen and you see a knife, something is just telling you maybe you should just cut yourself or cut other things or do something very, very strange. It actually wants to do a lot of things. The id, uh, according to Freud, brings about different adventurous ideas, brings about different um, immoral thoughts. Okay, now we have another thing which is called the superego. According to Freud, the superego is our understanding of moral, is our understanding of um, let me say the norms, the principles. Now, for example, when you're walking across a bridge and then the id tells you, okay, jump, 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 see how it looks like, jump. All right, now the superego now will tell you that, oh, it is not good to jump, this thing is too high for you, it's beyond your level. All right, this is not the right thing for you to do. Okay, it's more like the sense of moral. Now the ego will be the one to pick the decision by comparing the advantages and disadvantages of the id and the superego, trying to balance things between the two. Now, okay, so the ego now will help you to make decision between what to do. Okay, do you want to follow the id and bear the consequences, or you want to follow the superego and then repress the id? So now Fred is saying that when the id, that subconscious mind, is being repressed, is being suppressed, okay, it's not being allowed to do whatever it is it wants to do. All right, so the id is telling you jump, 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 and then the superego which tells you that, oh, this is dangerous, and then the ego now which compares the danger that is going to happen. Oh, I might break my leg, I might not be able to walk again. Oh, now when you try to suppress the id's thought, it has come, and then you try to suppress it, it can lead to avoidance of heights. Now I hope you're getting the point. So it can make the person, oh, I don't want to go to the bridge again because it's too dangerous. So there is this conflict, and then because you're trying to suppress that id, you do not want that id to overshadow your mind. You do not want it to win the battle. So you avoid the situation entirely. I hope that makes sense a little. All right, now symbolization. Phobia symbolize deeper psychological conflict. Now, developmental origin. According to Freud, this conflict arise at different psychosexual stages of development. All right. Freud also spoke about the um, anal stage. All right, anal stage of development, but I wouldn't want to be dwelling much on that because of the um, video length. Okay, now example study. All right, according to Fred, he actually did a study on little hands. There's a boy who has phobia for horse. Okay, phobia for horse. The boy is called Little Hands. Okay, is it the boy or the horse? Um, Okay, either of the two is actually called the Little Hands. I've forgotten. All right, now, background. 5-year-old Australian boy with a horse phobia. Okay, now, the study was based on a report from Hans' father. Okay, it's the boy that is Hans. All right, with Fred meeting Hans only twice. All right, so the father reported the case of the boy to Freud, and then they met only twice. Now, early life events, there are certain events in the boy's life that led to that. The boy is now 5 years old, but before that, when he was 3 years of age, the boy had interest in his genitals, all right, in his penis. Now, the mother threatened castration, threatened to cut it off, okay, leading to fear. So there's a fear around that because of the threat, okay. Now, sister's birth led to maternal separation, okay, when the mother gave birth to the boy's sister now, which is another child, all right. So there is a distance between the boy now and the mother, okay. Now, witness the horse fall and die in the secret. Now, this is also another thing that the boy experienced when he was young. He witnessed a horse that fell and died. Now, how did this phobia develop? Now, feared being beaten by a wild horse. That is his phobia. It looks strange because you might look like, okay, what is the connection between all of these and then the phobia for horse? Okay, is explaining that his phobia for horse is actually as a result of the phobia he has for something else. Okay, now Fred linked this fear to the Oedipus complex. Now, what is Oedipus complex? Oedipus complex basically talks about that a male child has this affection for the for the mother rather. Okay, a male child has affection for the mother, and there's another one, I've forgotten the name, all right, which explains that the female child now will have the affection for the father, all right. Now, horses in this situation, according to Fred, now symbolize the father, who is seen as uh, an intermediary between the boy and the mother. Can you see? All right. The horse now, because the horse has gray hair just like the father. Okay. Now, the boy, Fred is explaining that the boy had phobia for the father, fear for the father. He just transferred it to the horse. Now, fear of the horse reflected unconscious anxiety about the father's castration anxiety. All right. So, according to the to Freud, that is the explanation. Although I do not totally this is more like a theory, not necessarily like an experiment, right? So is a form of analysis trying to analyze the phobia situation based on existing theory. All right. So he believed that it's because the boy fear he might be castrated. So is that fear now? He doesn't want to see the father. And then since the horse now kind of pictures the father to the boy, so he's now scared of horse. You see? Something like that. Now, resolution. Hans' phobia declined around age 5. He also had fantasies where he had children with his mother, okay, symbolizing the Oedipal resolution. So he had this fantasy as well. Okay, he had children with his mother, that is the Oedipus complex, right? Okay, so that is the case of the hands, okay, according to psychoanalysis. Now, summary of our phobia explanation. We have the biological, which is genetic, inherited disposition to fear certain stimuli so that we can survive, right? We have the example study by Ost, and then finding strong genetic link for blood and injection phobia. Okay, there's also eye physiological response. Okay, now what about behavioral classical conditioning and operant conditioning? Phobia learned through association, okay, maintained through reinforcement also, which is the classical conditioning. According to Watson, the fear can be, that is the Little Albert experiment, okay, classical conditioning, right? Now, the psychodynamic phobia stems from unconscious conflict and symbolization. Unconscious conflicts and symbolization. Something represents something to us. Okay, you did a study on little hands. Us phobia linked to Oedipus complex. Phobia symbolized deeper anxiety. Okay, anxiety of the father, which is transferred into the horse. Now, moving forward, the treatment, right? Treatment and management. We have the behavioral therapy. There's a concept of systematic desensitization. All right. We want to reduce the sensitivity of something, but we want to do it systematically, right? Because phobic stimulus are very sensitive object, right? Now we try to reduce the sensitivity someone has for that. Okay, definition and purpose: a behavioral therapy used to reduce undesirable response to specific stimuli, particularly effective for managing phobia such as agoraphobia and every other ones. Now, theoretical basis: based on the principle of behavioral psychology, assuming behavior is a conditioned response. Okay, if phobia can be learned, then it can be unlearned. Can you see? All right, so looking at the behavioral category, so it's possible to learn phobia like the little Albert learned. Okay, he developed the thing over time. It's not natural. Fear for horse is not a natural thing for him, but he learned to develop it by associating, through association, right? Association of fearful stimuli with the rat. Okay, so if phobia can be learned, then it can be unlearned. That is the theory. Okay, now counter conditioning and reciprocal inhibition. Now, counter conditioning basically involves systematically desensitizing a patient so that a once frightening stimulus become neutral. Eventually, the stimulus provokes no anxiety. Now, what about reciprocal inhibition? Trying to control your behavior. Concept that it is impossible to experience two opposing strong emotion. Yeah, there's a concept of this according to Warp 1958 that you cannot experience two opposing emotion at the same time. You cannot be sad and happy at the same time, except you're just trying to use um what's the word now? A figure of speech, okay, to explain the situation. All right. Now, systematic. Basically, the idea is when you're experiencing um, phobia, there is this physiological arousal you get. There's this increase in high beat, right? Heartbeat, right? Okay. So what if you're experiencing calm? If you're being calm, then all right, you treat the person by teaching them an opposite behavior so that they can now go through their fear. All right. So systematic desensitization uses this principle by replacing fear with relaxation. So it's impossible now to be experiencing fear and relaxation at the same time, right? So you try to relax the participant as they move through their uh, phobic stimuli. Okay, put fearful feeling in conflict with deep relaxation and calm. Yeah, stages of systematic desensitization. We have the teaching relaxation techniques. All right, this includes uh, methods include progressive muscle relaxation, visualization, or even anti-anxiety drugs. So to be able to teach participants how to relax, relaxation techniques, right? Relaxation, muscle relaxation itself, visualization of this. Now, creating an anxiety hierarchy. This is very important for systematic desensitization. Therapists and patients collaborate together to create a list. All right. What is the most fearful? What is the least fearful stimuli? Okay. You try to arrange them gradually so that the less stressing will be the starting point before you move to the most extreme stimuli. All right. Now, the hierarchy progresses from least to most, right? Gradual exposure and relaxation. The patient work through each stage of the hierarchy, starting from the with imagined scenarios. So, especially if you're having a phobic stimulus for something, for example, maybe spider, they can start with imagination. All right. They're not using the real spider, and eventually they get to use the real spider. So it moves on to real life exposure. Once you're relaxed with the imagination, then you can move to real object. Okay. Now, example of anxiety, looking at agoraphobia. All right. So we have okay. Okay, so I think it's going to start from the fifth one. which is the least distressing in this situation. Okay, I think I should rearrange it on the other hand because this one seems smaller. Right now, walking to the end of the path. Okay, you don't want to walk in public, right? But then just start by walking around a particular path, right? Okay, can you do that alone? So they are taking out the exact phobic stimuli. The phobic stimuli can be the being around the public, right? So here is just a path. Okay, the second one is stepping outside the front door at least to be able to see things. So gradually moving to picturing being at a busy supermarket. So this is just a picture, but they are moving to the supermarket itself, right? They are moving to the supermarket itself. Now, picturing being in a quiet shop alone. Okay, now it's still picturing. Okay, sorry, I think it's the other way around. Yeah, I think I mixed it up. Yeah, I mixed it up. Now it starts with the picturing. Yeah, I arranged it well. Picturing walking to the front door. So it's actually a picture here, picture here, picture here. So these are basically like in the mind, and then becomes the real life. Stepping outside the front door. Okay, at least to go out. Someone that is avoiding those situations. So you try to go out and then walking to the end of the path. So this basically is like you're walking down the street. I I believe, yeah, we're walking down the street and probably at least walking down to the front of the supermarket. So it moves gradually from the least to the most distressing stimuli. Yeah, the hierarchy continues with increasingly challenging scenarios such as walking to the shop on the corner, entering the shop and buying one item, walking to the main supermarket and looking inside, stepping inside the supermarket and finally buying an item. So it moves gradually from the picture, all right, to the real life exposure. Okay, now effectiveness of systematic desensitization. All right, how effective is it? Research support, supported by research evidence. According to Agras in 1967, it's effective for treating agoraphobia. Okay, Kimura et al. To 1972, successful in reducing fear of snakes. Okay, now what about historical context? Decline in population in 1970s and 80s as other direct exposure therapy gain prominence. So there's a decline in it around this period because there are other form of treatment, other form of therapies, which includes CBT, right? Okay, yeah, we're going to look at a particular study, but before that, the key terms here, we have the phlebotomy, all right, which is drawing blood, taking blood for medical test, right? We have in vitro. What is in vitro? Imagine exposure to a phobia. This is imagination. You're not really seeing the phobia, or it's from your imagination. What about in vivo? Real life exposure to a phobic stimulus. All right, this is the real life, this is the imagination. Vitro is imagination, vivo is real life. Now, reciprocal inhibition, the concept that two opposing strong emotion cannot be experienced simultaneously, right? Okay, now moving to the key study by Chapman and Delap, 2014. They try to treat blood injection injury, that is BII phobia. Now, how did they do that? Cognitive behavior therapy, CBT, has been found effective in treating specific phobia. Okay, and Tony et al. 2001 claimed that BIR phobia differ from other phobias due to the likelihood of fainting. We mentioned that earlier, right? When exposed to the stimulus. Now, treatment focus. Treatment must focus on preventing fainting as well as reducing fear. So that's the treatment method. Okay? Yeah. What is CBT? Helps challenge and replace rational thought through thought with rational ones, right? What about systematic desensitization led to the development of applied tension therapy? Okay, applied tension now increased blood pressure to counteract fainting. Now, what happens during fainting is that there is reduced blood pressure in the body system. The blood pressure actually becomes low, so not pushing the blood, sufficient blood to the brain, which can actually cause fainting. Now, how can you tackle that? You apply tension on the body so that there can be increased blood pressure, increased movement. All right. So when the patient is undergoing like phlebotomy, for example, then they can teach applied tension so that that can help the blood to move well, so the patient can treat or control fainting. Now, the study by Chapman and Delap participant, they used a case study of a 42-year-old male participant known as T. He's diagnosed with BII phobia and major depressive disorder. Okay, the method: interview for life history, standardized questionnaire, which is the Beck's Anxiety Inventory, BAI. Okay, they also used Beck's Depression Inventory, BDI. We spoke about that earlier. Quality of life satisfaction questionnaire, okay, which is QLESQ. And then there is a blood injection symptom scale. All right. They didn't use BIPI here. It is BISS according to the study. All right. So they used all of this to measure the behavior and the ability to control fainting and the likes. Okay. Moving forward now, Chapman and the lab result. Before treatment, severe anxiety. Okay. Minimal depressive symptoms though, but there is intense fear of blood and injection. Now, during treatment, 9 sessions of CBT and applied muscle tension. All right. So they try to replace the thoughts, okay, challenge it, replace the thought with rational one. Blood doesn't kill, blood doesn't do that, you know. All right. And then they treat the thought applied muscle tension. Okay. Now, fear hierarchy was created and worked through using subjective unit of discomfort scale. All right. So they try to get the hierarchy using SUDS. Anxiety rating, okay, decreased significantly over session. Okay. Yeah. Using this one to measure this scale SUDS to measure the anxiety, they discovered that as they move through the hierarchy, it decreased, the anxiety level decreased over multiple sessions. Now, after treatment, patient successfully underwent phlebotomy with minimal anxiety. Now, can you see? All right. So 4, 10, and 12-month post-treatment, sustained improvement. The improvement continues. No longer met criteria for BII phobia. So that means that what? CBT can be used to treat anxiety, BII, okay? However, take note, CBT in collaboration with applied muscle tension, okay? Very important. All right, so Chapman and Delap, 2014 conclusion. Its effectiveness. This shows that CBT demonstrated successful treatment of BII, phobia, and applied tension. Now, outcome. Patient who previously fainted during medical procedure was able to undergo medical treatment with minimal symptom after the therapy. So the patient can now undergo medical procedure after receiving the treatment. Okay, evaluation of the study by Chapman and Delap. Strength. Case study allows for in-depth understanding of the individual experience, right? Multiple techniques use questionnaire and interview, providing both quantitative and qualitative data. Limitation, you cannot generalize. Lack of replicability, it is not, because it's a unique patient, you can really replicate the exact thing over and over again, okay? Because the other person, or let me say other participant, might have different reality. Okay, so that is it. Thank you very much. I believe you've learned one or two things about the anxiety disorder, and I believe that this video has simplified the content for you. All right, so ensure you stay tuned to watch my other videos. All right, so also please try as much as possible to subscribe to my channel and then like my videos. All right, thank you very much to those that have already done that. All right, I wish you all the best in your studies and in your goal and desire to deepen your knowledge as regards psychology. Okay, so thank you very much and goodbye.